Good morning. Welcome to today's tutorial. I am your presenter, Mr.Mwanza, medical licentiate. Today in pediatrics, we're going to talk about NEC, which is necrotizing enterocolitis. So this is a syndrome of acute intestinal necrosis. And we know that when we talk about necrosis, this is basically the dying of the tissue due to low supply of oxygen. Okay, so when we talk about necrotizing enterocolitis, it mostly affects the preterm infants, okay, those infants that are born before term. And the occurrence of NEC, it happens in the first week of their life. Okay, so the risk is inversely proportional to the birth weight and the gestation age of NEC. So the mean gestation age of infants with NEC is in the ranges of 30 to 32 weeks. And infants are generally appropriate for gestation age in between 7 to 10% to those of the full-term infants. So the parts that are most of the organs of the body, when you look at the GIT that are most affected are the distal colon, the total colon, and the cachium. Okay, so these they are affected with a complete spectrum from the mucosa to the transmural necrosis. Okay. So this is the most common serious surgical disorder that happens in infants, most those that are under intensive care unit. So if we look at the incidence or the prevalence of necrotizing enterocolitis, it's between the preterm infants 3 to 4%. For those that are less than 2,000 grams. Okay. So also the risk of NEC declines with the gestation age as it increases. Because we know that as the gestation age increases, even at this period of time now, the organs of the GIT and other body organs that may be involved have fully matured. Let us look at the etiology, okay? So far as with studies that have been taken, the most causative etiology still remains to be unknown. But we base our diagnosis looking at the risk factors that will bring about necrotizing enterocolitis. Most of them we can divide them into two as maternal disorders and infant. If we start with the infant disorders or the infant risk factors, we may talk about infections. These will look at the early neonatal sepsis. Also, we can talk about respiratory distress syndrome. This is a topic that was discussed in details, we understand it. Also, we may talk about hypotension and hypothermia. Above all, also, we may look at causes like prematurity. If we focus on the maternal disorders, the most common causative is preeclampsia, eclampsia. So the pathogenesis in necrotizing enterocolitis, it involves three major things, okay? In these risk factors, the first one that we can look at is the prematurity, which stands to be the main risk factor. We also look at hypoxia, okay? So when we talk about hypoxia, what is happening is that it will bring about ischemia to the bowels, the organs of the GIT. As a result of this ischemia, it will lead to reduced blood flow. And you know that once there's reduced blood flow to any part of the organ, this is where the necrosis now comes in. So we'll also look at the third risk factor on our pathogenesis, which is feeding, okay? So you know that these prematurely born infants, when there's a rapid increase of feeding, here more important what we're talking about is introducing these infants to formula feeds. Also, we may talk about the hypertonic formula. The last one of all is infection, okay? So bacteria in the intestinal wall and the bloodstream also may lead to necrotizing enterocolitis, which is the NEC. So all the above four risk factors that I've mentioned there, they're the ones that stand in the pathogenesis of NEC, which may lead about what ischemia and leads to infection to the what? To the intestinal mucosa. Okay, so let us look at the consequences of NEC now. Okay, so mostly what happens is that NEC affects the GIT, and in severe cases, it may bring about profound impairment of multiple organs that are involved. Okay, so what is happening is that the distal part of the ilium and the proximal segment of the colon, they are the ones that are at high risk, or they're the ones that are mostly involved here. The pathogenesis of this disease mostly involves the significant inflammation of the intestinal tissue. So once there's inflammation, we know that the release of inflammatory mediators like the TNF, the leukotrienes. So what will happen is that the leukotrienes and also in the intraluminal bile acids, they are also what? They are all produced due to the inflammation that is occurring. So with this, there will be a downregulation of what? Cellular growth factors. All of this will lead to a degree of what? The intestinal damage. As a result now, neck being at its peak. Okay? So the triad of intestinal ischemia, what is happening is that there's enterofeeding and the pathogenic organisms have been they've become strongly linked to the what? To the disease of neck. Okay? So what is happening is that this disease, it results from the interaction between the mucosa, which is caused by various factors. And these various factors are the ones that we're talking about, like ischemia, infection, and inflammation. So all these, when there is an interaction of the ischemia, the infection, it will bring about to the what? To the host response, which will bring about the injury to the bowel. Okay? So there are a lot of various bacteria that are involved here. So that when you do the investigation, which we talk about later, these are the things that are cultured. We may talk about E. coli, Clostridium, Papillogens, Staphylococcus, Epidermis, and the rotavirus. These are most of the things that are isolated when you do a blood culture in these infants with neck. So the intestinal necrosis now, it results into the breach of the mucosa barrier. Because we know that with the exposure of this injury, there's an interaction now. There is the wash away of the mucosa barrier. When there's a wash away of this barrier, it will allow bacterial translocation and migration. So which means that the surfaces have been exposed. These bacteria now, they can freely do what? Translocate themselves, and they can easily migrate. Okay? Which will bring about endotoxin, and this will result into the damage of the tissue. So the endotoxins, what they will do is that they will interact with the PAF and the pro-inflammatory molecules. So once there's this interaction, which means the inflammatory response now has been what? It will speed up. Okay? So main factors may contribute to the development of the necrotic segment of the intestine. We look at gas accumulation in the submucosa of the bowel wall, and there will be a progression of necrosis due to the what? To the perforation, sepsis, and death. So what is happening is that because of all these inflammatory factors, the disease, the ischemia that has come, we know that when there's ischemia here, there's reduced blood flow, and the tissue is dying. When the tissue dies, here what it means that there is no communication between the two tissues. What will happen is that this bowel will do what? It will perforate. When there's perforation of the bowel, there are high chances that infection will come in the form of sepsis, which will bring about death to this what? Infant. Okay? The major fetal causes what is happening, because you know there where there is necrosis that has happened, there is gangrene that may form. Okay? So this gangrene that has formed, it can easily spread. So it may extend even to the stomach, even to as far as to the rectum. So in most of the cases where neck occurs after the initiation of enterofeeding, and it is less common in infants fed by breast milk, because you know that these infants that are born and being breastfed on breast milk, it protects the mucosa lining of this infant. Okay, so if we introduce them first to this enterofeeding, these other types of milk, this predisposes them to the development of what? Neck. So in preterm infant, the mucosa lining there, or the mucosa cellular, it is not fully matured. Okay. So what is happening there is that in this infant who are born at preterm, there's an absence of the what? There's absence of oxidative mechanism. So what is happening is that it predisposes it to all any other infections that may come with it, and making it become prone to what? to injury. So if we feed these infants with breast milk will provide that mucosa protective that will help them prevent what? Prevent infection. Because we know that breast milk contains secretory immunoglobulin, IgA. So this IgA, it binds to the intestinal immunocells, which prohibits bacterial transmural translocation, making this infant who's fully matured less at risk of developing necrotizing enterocolitis. Other constituents of breast milk is that it contains the interleukin 10, which is the growth factors, and erythropoietin, which may also play a major role in mediating the inflammatory response. So we will look at the clinical features of NEC. It has a variety of signs and symptoms, which may be either insidious or sudden catastrophic in onset. So what onset of NEC, the clinical features usually occurs in the first week, in the first to second week for those who are full-term babies. But it can go as late as 3 months of age in those premature babies, because we know that they're still in the process of what? Developing. So we know that necrotizing enterocolitis, most it's affecting the GIT. So we'll focus so much on the presentation of it under the gastrointestinal system. Okay. So what you'll find on the abdomen, you find that there is abdominal what? Distension. Because we know that this abdominal distension is coming from the what? It's like this is it's a colon which is unable to allow the passage of other contents of the abdomen. So they are just being piled up in one part, like they form like a pool there. So as a result, they have no any other way out. There will be accumulation of these abdominal contents. This is when now the abdominal distension will come in. Also, you find that when you try to palpate this abdomen, there is tenderness, or we say there is guarding. So in these infants, you also find that there is poor feeding habits. In exemption of that, also these infants will present with delayed gastric emptying, because we know that there is a miscommunication somewhere there. So even if the empty now is what? It's altered. Also, they will present with the vomiting. If at all there's gastric emptying there, you find that there's diarrhea, which is what? Blood stain. On examination, it's the same thing that you find. If you palpate this abdomen, there's a mass that is palpable, and there is a rebounding tenderness even as guarding. If you do an auscultation of this abdomen, you find that there is absence or decreased bowel sounds. If you look at the systematic features of presentation, this is where it's the high chances that this infant may present with shock. There may also be metabolic issues like respiratory acidosis. Okay, there is also temperature instability. There may be fever or hypothermia. There is also decreased perfusion. Also, you find that there is a positive blood culture. So what investigations are you going to do for this infant that you are suspecting with those signs and symptoms, with those features that the infant has presented with? It is important to do a full blood count. We know that there is a marked elevation here of the WBCs also. And if you do a full blood count, you'll find that there is leukopenia. Okay. Also, if you look at the hemoglobin, which is HB, there is anemia of prematurity. But also, what you should know and keep at the fingertips is that the thrombocytopenia is highly associated with the necrotizing enterocolitis. The other investigations that you're going to do is you do a blood culture. So if you do a blood culture, you know that you may trace either any of those organisms or that are bacteria that are highlighted earlier on. The Staphylococcus, the E. coli, those are the things that you do you might find when you do a blood culture. You also do a serum electrolyte. When you look at the sodium, the potassium there. So you can also do the arterial blood gas, which can aid in the determination of the infant's need for respiratory support. Okay, this also may help us look at the acid base status, because you know that the other systematic features that present with these patients, there are things like respiratory acidosis. Abdominal radiograph is the mainstay of diagnosis for necrotizing enterocolitis. Okay, so we can do an anterior-posterior abdominal radiography on the left lateral debuticals. Also, the radiography is from. So this will basically help us to assess the disease prediction or progression. Sorry. So, what are the findings when you do an abdominal X-ray? What you find is that there will be dilated droop. Okay, so if you look at an X-ray, um, this X-ray for necrotizing enterocolitis, if you have enough time, you can go on Google. Try to Google for presentation of necrotizing enterocolitis on an X-ray. So what you see is that there will be thickened bowel. Okay, so once you see that this bowel looks thickened, it is a result of what? Edema and the inflammation that is taking place. Also, you find that there is the abnormal gas pattern on this radiological finding. Okay, so if you do an abdominal ultrasound, what you see if you are suspecting necrotizing enterocolitis in unit, what you find is that there is loculation, and you may also see that there's a formation of abscess consistent with what the word of or G2 perforation. So also on ultrasound, what is visible is what we call as the portal area. Okay, it is observed as bubbles in the venous system. It was formerly called as the champagne sign. You know how the champagne performs. If you pop up the champagne, so if you do an ultrasound on this, there's a presence of the bubbles. This is what is called as the champagne sign. What is the management of necrotizing enterocolitis? So first things first, in these infants, what you do is that you secure the airway and breathing. So it falls under the primary survey, the ABC. Okay, ensure that there is continuous breathing in these infants. Also, you maintain adequate oxygen and ventilation. Okay, so what you should know that you said on the presentation of these babies that they'll present with the abdominal distension. So this abdominal distension also may compromise the breathing of this infant. So it is important to do to decompress the abdomen. Also, what you do is you establish your vascular axis. We give intravascular volume replacement. We're talking about IV fluids here, where we have to transfuse this infant with the fresh frozen plasma, because you know that they may also present with the anemia of the premature. Also, we give them saline. Also, it is important to collect the metabolic acidosis, where we'll place a large bore nasogastric tube, NGT. But important of it, we know that there's a compromise in the mucosa there. So we'll start these infants on On NPO, meaning that we'll put them on new peoro on pills. On the medical management, we'll go in with broad spectrum antibiotics. We know that there is a presence of other bacteria and organisms that are also grow from them. So in our management, what we do is that we'll cover them with a gram positive, which is fragile. We'll also cover them with a gram negative, which is ampicillin. And also we should ensure that anaerobic coverage, we put them on gentamicin. It is important also to do to treat all coagulopathies that may arise, so that we avoid any bleeding complications. Something very important to consider also, we do we monitor regularly. Here we monitor the clinical status of this infant. Also we do radiographic and laboratory investigation. So what is important is that once we are monitoring this infant with necrotizing enterocolitis, we should know that this condition it can worsen quickly. So we should also go to another intervention that we do for these infants, where we go into now the surgical management. On the surgical management, we have two options. We can do what we call as the peritoneal drainage at the bedside, okay? This will allow systemic stabilization and recovery in the what? In the smallest or sickest infants until they become better surgical candidates. Because we know that these infants, we are dealing with two types here. Those that have reached the fully mature, and those that are premature. So for those that are not fully tamed and they're not ready for any surgical procedure, in these are the ones now that will do what? The peritoneal drainage at the bedside. But if this infant is ready for surgery, we can do what you call as the laparotomy, resection of non-viable bowel, and we also do what you call as anastomosis. Okay, so here we may, well, what happens is that we know that there's necrosis that has happened. In other cases, you may find that gangrene has also started to form. So what we do is that in laparotomy now, we'll get that colon that is affected, we cut off the part of that intestine. So when we cut it off, we remove it to prevent the spread of what? The gangrene there. And we'll do what we call as anastomosis, which means the joining of this intestine. So we know that once we join it, we cannot allow the use of intestine at that very moment. We will allow healing to do what? To take place. So what we do is that this is where now we form what we call as an ileostomy or a colostomy, whereby we will have an opening on any part of the upper part of the abdomen, where this patient, this infant now, we use that opening as the source of toilet until we ensure that that part where anastomosis was done, it has done what? It has fully healed. What are the indications for laparotomy? What you should know that anytime when there's bowel perforation, this happens as an emergency, and this is a surgical procedure that is supposed to be what? To be done. Okay, so what we do is, what you see is that when there's bowel perforation, if you do an ultrasound, you find that there's air fluid what levels. Remember, I also talked about the champagne sign. Okay, so also another indication that will make us go into surgical intervention is that we try to do the medical management, but there is nothing that has happened, or there's failure to do what? To resolve. We know that in surgery, sometimes we expect complications, or there may be no complications, but some things that we will look at also is that the complications that will arise from necrotizing enterocolitis even before surgery. The things that the immediate that will happen is the perforation, peritonitis, anemia, and shock. So what is happening here is simple. For the perforation to occur, remember I said that there is hypoxia to the valve, which means there is reduced blood supply. And you know that this supply, it carries a lot of things. It carries oxygen for the survival of all the tissues in the body. So there is no supply of that oxygen, which means if this colon is deprived of oxygen, what will do now to this tissue? There will be what you call as necrosis. As necrosis occurs now, which means this tissue will do what? Will die. When it dies there, this way sometimes now, the sepsis infection may come in. As it comes in, it will bring about what? Peritonitis. Also, we know that with this perforation, also sometimes there may be there is blood that's going away. As a result of that loss of blood, the anemia is coming in. In exemption of that, we know that for the body to fully function, there's supposed to be a balanced hemostasis between the extravascular fluid levels and the intravascular fluid levels. So there is an imbalance that is happening there. As a result, now the shock is going to do what? To come in. And most of the times, the kind of shock that you find here is hypovolemic shock. Let us look at the long-term complications. The long-term complications, these are the ones now that will come in after surgery. We'll talk about the shotgun syndrome, also intestinal strictures that are formed as a result of surgery. So, but if we look at the survival, approximately 75% of all patients after a good surgery has been done, um, there is a good outcome and with less complications. If we look at the intestinal strictures, it develops in between 25 to 33%. Okay, most in infants with or without a preceding what? Preceding perforation. Most likely location of acute disease is the terminal ileum, but most of the strictures here now they involve the left side of the colon. Symptoms of feeding intolerance and bowel obstruction may be present, but these usually occur 2 to 3 weeks after recovery from the initial event of the what? The surgical procedure. Okay, so the presence of location of obstruction in case of, because you know this obstruction will come as a result of the late complications and strictures. We can rule them out by doing what? A contrast enema. Also, we can also do a surgical resection of the affected area if there is need, and we fully confirmed with the contrast enema that there is an obstruction. Necrotizing enterocolitis is preventable. The question is how. So here, what the importance now is having a good antenatal teaching to these pregnant women, and also breastfeed babies have a lower incidence of necrotizing enterocolitis more than those that are studied on formula fed. Also, proper screening and management during antenatal. Here, we know that we're talking about conditions that may bring about placenta insufficiency. Why are we concerned about these conditions? We know that this infant, when they're still in the uterus there, their survival depends on the uteral exchange, the placenta exchange, for the gaseous exchange and anything. But if there is a condition that compromises the placenta to supply uh, the fetus with its requirements, such conditions like preeclampsia, hypertension, these are also part of the things that may bring about necrotizing enterocolitis, because we know that there are high chances that they will be born as premature babies. Okay, so also it is important also to do the postnatal screening, okay, for conditions that may diminish what splenic blood flow, such as ductus arteriosus and any other cardiac diseases that may compromise or put these babies on at risk of developing necrotizing enterocolitis. Okay, because the air presentation of neck is subdural, which means we can lightly take it because the presentation is sometimes to start like in a mild case whereby it's not really an emergency. So it is very important to pay attention to every infant with any signs of feeding intolerance or any other abdominal pathology that may be observed. So if we see or we found any of those risk factors that I talked about in these newborn infants, it is very important to do what? To put them on NPO, new pain, or, and also ensure that there is aspiration of any gastric contents once we are suspecting what? Necrotizing enterocolitis. Typical recovery from necrotizing enterocolitis, if medical or non-medical treatment succeed, in between 10 to 14 days or more, without any oral intake, we expect a good recovery as a good prognosis here. Okay? What may compromise the recovery of necrotizing enterocolitis are conditions that frequently accompany prematurity. Okay? So thank you so much for watching this video and tutorial. In case of any queries, anything that you did not understand, when you go through the notes and the video, you can share, put the questions on the YouTube channel, I'll respond to them. Take time also after going through this tutorial to look at the first slides from slide 1 to 18. There is a case scenario that of a patient that I took history the time I was at school. So you look at it on how the presentation and how the management was done until the last part of the history taking. Thank you so much.